Fatty tumors, lipodermoid, carcinoma formed of mature white fat cells in temporal subconjunctiva. There is deep orbital extension, fibrous septa in between, and thin fibrous capsule. Liposarcoma, it could be very rarely primary or secondary to orbital radiation in retinoblastoma, well-differentiated type. Liposarcoma, primary, very rare, or secondary to orbital radiation in retinoblastoma. Types, well-differentiated type and myxoid type. Lymphoid tumors. Orbital lymphoid tumors represent an extranodal site affection. Lymphomas represent 10 to 20% of orbital tumors, only 2% associated with systemic lymphoma. Types, benign lymphoid tumors, reactive lymphoid hyperplasia, or malignant lymphoid tumors. Cell types, mostly non-Hodgkin's B-cell type. T-cell lymphomas are rarely seen in the orbit. Average age affected by lymphoid tumors is 50 years. There is insidious onset of painless, progressive, and moderate proptosis. The conjunctiva shows salmon patch appearance. There are no inflammatory signs. 90% of orbital lesions involve superior orbit behind septum. More than 40% of the lesions arise in lacrimal gland and affect palpebral lobe. 17% of lymphoid tumors are bilateral. Pathology. Putty-like rubbery soft tissue molded by tissue planes. Infiltrate may have straight-line angulations. Bone destruction is rare, except in rare cases of multiple myeloma. There is diffuse pancake-like enlargement of lacrimal gland molds to globe, projects anterior to orbital septum, palpebral lobe. Extraocular muscle cases usually involve one muscle, with no fibrosis, and the motility is normal. Ocular adnexal lymphoid tumors may be classified according to cell surface markers or DNA hybridization techniques into monoclonal B-cell non-Hodgkin's malignant lymphomas 70%. Most of these are low-grade. Polyclonal lymphoid hyperplasias 30%. Types of orbital lymphoid tumors. Reactive follicular benign lymphoid hyperplasias. There is polymorphic infiltrate with mature lymphocytes, plasma cells, histiocytes, and eosinophils. Germinal centers with large lymphocytes with few mitoses and macrophages. A zone of small lymphocytes surrounds the collection. Immunohistochemistry. Polyclonal. T-cell rich. 60% T cells, mainly T helper. B cells are present. Absent Dutcher bodies or anaplasia. Atypical reactive lymphoid hyperplasias. Cytologically intermediate, borderline, or gray zone lesions. Represent 11% of lymphoproliferative adnexal lesions. Monomorphic lesion with scanty or no follicles, composed of well-differentiated lymphocytes. Immunohistochemistry discloses that 70% of atypical lymphoid hyperplasia are monoclonal, meaning low-grade B lymphocytic lymphoma. Malignant lymphoma, monomorphic infiltrate. More than half of ocular adnexal lymphomas are low-grade small B-cell lymphocytic lymphomas. 78% are low-grade small or intermediate lymphocytic lymphomas. Most ocular lymphomas are diffused, 16% follicular. MALT lymphomas, mucosa-associated lymphoid tissue or marginal zone lymphoma are common. MALT-type lymphomas, 50% arise in GIT. Extranodal MALT-type lymphomas arise in association with mucosa or epithelial structures. Ocular adnexal marginal zone lymphoma refers to same histologic or ultrastructural pattern to MALT-type lymphoma and not a predilection for mucosal or epithelial sites of origin. Pathology. Poorly formed follicles. Heterogeneous cellular composition of small atypical cells, small lymphocytes, and plasma cells. B-cell population may expand the marginal zone and infiltrate follicles. Rare systemic dissemination is present. Large cell type transformation in 20% of cases. In MALT-type lymphomas, there is B-cell immunophenotype. CD5 and CD10 are negative. Classification of orbital lymphomas. Histologic classification of 69 ocular adnexal lymphomas, Knowles and Jacobiak. Small lymphocytic 45%. Small lymphocytic plasmacytoid 11.6%. Intermediate lymphocytic 21.7%. Small cleaved 11.6%. Mixed small and large cell 2.9%. large cell 7.2%, total higher grades 21.7%, total small or intermediate 78.3%. Revised European American Lymphoma Classification, REAL, for adnexal lymphomas, marginal zone lymphoma, mole-type lymphoma, diffuse lymphoplasmacytoid, lymphoplasmacytic lymphoma, follicle center lymphoma, diffuse large B-cell lymphoma, and other rare types. All orbital lymphomas are monoclonal B-cell tumors composed of more than 60% B lymphocytes. Monoclonal B cells have only one type of light chain, kappa more than lambda. Immunophenotypic lymphocyte typing studies are best performed on fresh, unfixed tissue. Flow cytometry may be performed on fresh tissue. Prognosis of lymphoid tumors. Systemic involvement in ocular lymphoid tumors. The site of involvement and the cytologic type of lymphoma do correlate with systemic disease. Site: conjunctiva. The cytology shows small intermediate lymphocytic type. Extraocular lymphoma is less likely, 20%. Eyelid anterior to septum affection shows higher grade lymphoma with more likely extraocular lymphoma, 67%. Orbital affection shows monoclonal B-cell lymphoma with intermediate extraocular lymphoma incidence 30%. The single most important prognostic factor is the extent of the disease discovered after a thorough clinical staging at the time of initial presentation. The vast majority of patients presenting with a clinical stage 1E ocular adnexal lymphoid proliferation, unilateral or bilateral, have a benign indolent clinical course. Systemic evaluation should include bone marrow biopsy, CT body scans, PE and chest X-ray, CBC with differential count, cell sorter analysis with monoclonal antibodies, Coombs and SPEP. Other lymphoid tumors. Plasma cell tumors are rare. Plasmacytoma, plasma cell-rich pseudotumors, multiple myeloma associated with bone destruction, mitosis. Lymphoplasmacytic lymphoma. Walden's-Storms macroglobulinemia. Ducher bodies, intranuclear eosinophilic inclusions represent sequestration of cytoplasm containing immunoglobulins. Hodgkin's disease, Burkitt's lymphoma. Other lymphoid tumors also include mycosis fungoides, T-cell cutaneous lymphoma, convoluted cerebriform nuclei, Potrier abscesses, lymphoid hyperplasia of the uvea, leukemia, granulocytic sarcoma, chloroma. Granulocytic sarcoma, chloroma. It affects children. Myelogenous leukemia is the etiology. Pathology: proptosis, subcutaneous periocular masses, leukemic cells infiltrating tissue. Leather stain demonstrates cytoplasmic granules, esterase and lysosomal enzymes. Granulocytic sarcoma, chloroma. It affects children. Myelogenous leukemia is the etiology. Pathology: proptosis, subcutaneous periocular masses, leukemic cells infiltrating tissue. Leather stain demonstrates cytoplasmic granules, esterase and lysosomal enzymes.